patient, Richard, or otherwise known as Rick, is a 35-year-old male father of 3 rowdy boys. In his spare time, he likes to coach his son's Little League baseball team, and as an occupation, he works as a mechanic. He came to our clinic and presented with a right UCL tear in his dominant throwing arm. Okay, so some of the anatomy of the elbow. The UCL is located on the medial aspect of the elbow. It's a triangular shape as a whole coming off of the medial epicondyle and inserting on the coronoid and olecranon processes of the ulna. It has 3 bands, the anterior being the strongest, provides the most valgus stability and is also the most commonly injured. Posterior is the weakest and transverse really provides no valgus support at all. Just a little more anatomy. Coming off of the medial epicondyle is the common flexor tendon. It overlays the UCL and is often released in surgery. And one other important consideration is the ulnar nerve that runs behind the medial epicondyle and under the common flexor tendon. So this is just a picture of like a full thickness tear. This is like an example of where they could incise that common flexor tendon during surgery. So the mechanism of injury is just repetitive medial stress to the elbow. So very common in overhead sports, baseball, volleyball, softball. Some signs and symptoms are medial joint pain, swelling, decreased muscular strength, possible numbness and tingling from the contribution of the ulnar nerve, some instability depending on the thickness or depth of the tear, and some loss of velocity and accuracy in overhead throwing. And again, just keeping in mind the ulnar nerve irritation associated with like 40% of UCL tears. Surgical treatment versus non-surgical. So with non-surgical, you can get away with just doing braces, using NSAIDs for pain, and they can be back to full participation in 3 to 6 months. All this is dependent upon like patient preference, patient lifestyle, degree of the tear. In Rick's case, the degree and the lifestyle is what put him into the surgical category. Oftentimes during surgery, they will take a graft from palmaris longus, which is absent in quite a few people. So in that case, they will take something from the hamstring, the knee, or the foot. They can be back in full participation in 8 to 12 months. So another important consideration is the bracing between surgical and conservative. So conservatively, they're a lot more lenient with the range of motion, and then they only wear it until they're pain-free. Surgical, right out of surgery, they're locked at a 90-degree position, and only until week 6 will they be considered to discontinue the brace and allow full range of motion at the elbow.
Okay, so right out of surgery, we're going to start phase 1, which is our passive phase, 0 to 3 weeks. Main goals here as a whole is protect the surgery site, decrease pain, spasm, and swelling, and maintain some shoulder range of motion and strength without irritating the elbow. So treatment guidelines, we're going to follow the bracing protocol as demonstrated in the last slide, but we can start some submax isometrics for the shoulder, including internal rotation, abduction, and biceps. We want to avoid the external, as that puts the stress on that medial part of the elbow. Continue with bracing as needed through this. We're going to start some wrists and fingers, just active range of motion as Brooke is demonstrating. We're also going to do some wrist and elbow isometrics with flexion and extension. So just no movement there, just providing the submax isometrics. Week 3, we can start passive as a clinician, and we're going to start some light straight plane exercises. Some of the ones that we wanted to focus on in these pictures are our scapular squeezes. We want to maintain that scapular strength, as well as some ball squeezes to work on a little bit of strengthening for the finger flexors. And our next phase, the active phase, in 4 to 12 weeks, goals are going to be to increase the active range of motion, as well as increase elbow muscle strength. So here, weeks 4 to 5 in the beginning of this one, light resistance isotonics for active assisted wrists and fingers. Week 6, we can continue with straight plane exercises, increasing resistance, such as biceps, triceps, with a light weight. And then proprioception, non-weight bearing. That one will be with the patient's elbow right by their side. The clinician can apply some very light rhythmic stabilizations as non-weight bearing proprioception. In weeks 6 to 8, we're going to actually start weight bearing, discontinue the brace, and at that point we should be at full range of motion. Key thing here is we want to avoid valgus stress because that's where our surgery site was. So here is kind of a progression of exercises through this phase, starting with some resistive like gripping and then finger extension. And then we're going to work on some active assisted pronation supination with like a weighted dumbbell or a hammer as we have here. We already showed the bicep tricep single plane. And now we're going to continue with the shoulder strengthening, but with some therabands now instead of isometrics. And if we have the tool, like a TheraStick, we can turn like this, working on like his work. We'll be primarily using those wrist pronation supination. And like Brooke is showing there, we can do a minute of pronation, a minute of supination, as well as turn it, make it a little bit more challenging. Here we're going to start some weight-bearing proprioception with weight shifts on the edge of the table. And then Brooke can get on her hands and knees on the table. A little bit more advanced, just weight shifts with a little bit more weight on there. Alright, so phase 3 we move on to resistive. Goals here is we should be at full range of motion, elbow, wrist, and fingers. And we're going to try to achieve normal strength of elbow, wrist, and hands. We're also still attempting to maximize the rotator cuff scapular strength. So, treatment plans, we're going to start multi-planar activities with D1 and D2 patterns, and now we can use like a TheraBand as resisted. We're also going to do some dynamic proprioception, such as rhythmic stabilizations and oscillations. We're going to initiate plyometrics and begin throwing mechanics. We'll show you some pictures. So there's the D1, D2 pattern. Brooke is in place to do some rhythmic stabilization with the clinician applied as she tries to keep it still. And then we can progress that to against the wall with the physio ball as she does like a T pattern. I can also advance it by coming over here as a clinician and also providing rhythmic stabilization there. Further progression for proprioception is Brooke can be in a plank position on the Bosu ball and providing a T pattern there, and we'll progress that in the phase 4. And then working on our plyometrics as well as beginning our throwing mechanics. can
I can't catch.
do against the wall oscillations like that. And then progress to against the trampoline where they have to throw it with a little bit more force and then catch it on the back part. So our aggressive phase, phase 4, 21 through 36 weeks. Our goals here are pretty much to return Rick to his functioning work and Little League coach. Normalize performance in all activities, proper throwing mechanics, strength and endurance. Initiate sport-specific return. Progressive throwing program, analyze full body mechanics here, initiate activity-specific return. So we have is a progression from the plyometrics and the proprioception ones that we did on the Bosu ball. And it's kind of like up-downs. This works core, elbow, shoulder, and we can also provide a little bit of extra lower extremity by doing jacks, and we won't show that on the table. Moving on to more of his work specific, we can try to simulate like tire rotations as Brooke is showing there. We can put weight on the ends of those to make it more progressive. And then also we wanted to work on some overhead activities with starting out with like a punching bag up top to work on endurance, followed by we can have him hold some putty or even some tools if we have them, and kind of do rotations above his head like it's shown in this picture. And lastly, we want to look at his throwing mechanics where we don't just want to look at his elbow, we want to look here at his stance, like his other shoulder, his throwing shoulder, the cocking phase, the acceleration phase. We want to kind of analyze everything to make sure it's proper body mechanics during that throw. And then we return him to work and is coaching Little League.
References, citations.